Ok, buonasera a tutti, benvenuti a questo corso che è relativo alla gestione delle bronchiectasie, un argomento, alla gestione del paziente bronchiettasico, un argomento decisamente di interesse e di importanza notevole, anche perché, come ben sapete, negli ultimi decenni questa patologia per lungo tempo abbastanza diciamo sottostimata, trascurata, anche diagnosticata e trattata in maniera non sufficientemente approfondita per tutta una serie di ragioni, oggi invece è stata oggetto di numerose nuove evidenze che ci consentono, sia per il progresso negli approcci diagnostici, sia per nuovi studi dal punto di vista degli approcci della gestione del paziente, ci consentono di affrontare questa problematica in maniera molto più organica, più approfondita e soprattutto di mirare a un trattamento personalizzato di questi pazienti e di questa patologia che ha un'eziologia, come sapete, molteplice. Oltretutto sapete benissimo che si tratta di una patologia rara che è stata a lungo tempo anche trascurata dall'industria per quello che riguarda l'approccio gestionale e terapeutico, e questo ovviamente ha avuto dei riflessi anche sulla, come dicevo, su una gestione non approfondita e non adeguata del paziente, che oggi speriamo appunto siamo sicuramente in via di migliorare. Come sapete, è stato a livello europeo istituito un registro dei pazienti con bronchiectasie e qui abbiamo dei rappresentanti di questo progetto che si chiama EMBARC. A questo punto io non voglio togliere ulteriore tempo ai relatori, consentitemi solo di salutarli in inglese, essendo, come sapete, come avete visto, essendoci due relatori stranieri. So I would like to thank a lot our guests from abroad, our speakers from abroad, that are outstanding speakers in this field, that worked a lot in this field, and so I'm sure that their contribution will be very important, very relevant, and so thank you again for your contribution and for having present in this symposium, in this course. We can start. A questo punto io passo la parola al professor Aliberti, che presenterà i ultimi due speaker e le loro relazioni. Prego.
Grazie professoressa. So it's my pleasure to have both Amelia Schumerk and Peter Koemin in this symposium. We will start with Peter Koemin. Will give us a lecture on 5 points for the bronchiectasis management. Dr. Koemin is coming from the respiratory medicine department of the Nicolas Hospital at the St. Nicholas in Belgium. He's an author of the latest international guidelines on the management of bronchiectasis and active members of EMBARC. One of the major contributors in the increasing awareness and increasing evidence in the bronchiectasis field over the past 10 years. My pleasure, Peter, to have you here, and thank you for accepting our invitation to give this talk. The stage is yours.
Thank you so much for the invitation and for that perfect pronunciation of my family name. It's not so easy, but you have put me in front of a difficult task. I will first share my screen with you so we can start a presentation. You've given me the difficult task to give a presentation on 5 punti per la gestione della bronchiectasie in only 15 minutes. So let's get started, I would say. And the overview of the 5 key points, you can see it here. And let's start out with something quite obvious, but I think it's important to emphasize the importance of the difficulty of treatment compliance, because in my clinical practice, and maybe later Stefano can confirm this as well, 8 of 10 times when a patient comes and has a deteriorating problem, it's often treatment compliance that will be the cause of the deterioration. And if we look at the literature, it's obvious that compliance seems to be perfect in all these trials. But fortunately, McCullough had made a very nice paper on the real life situation of compliance and adherence. And there we see very low, very disappointing numbers, where we see only 50% adherence to inhaled antibiotics and respiratory medicine, and only a 40% adherence to airway clearance techniques. Now they further looked into this and looked, what is the reason that patients do not comply? And this is very interesting to realize as a respiratory physician, or a general physician for that matter, and that first and foremost, the beliefs about the treatment are very strong predictors for adherence. So your patient needs to believe the importance and why you are giving them that treatment. Also, with age comes wisdom. So for each 10 years an increase in age, the adherence triples. And also, quite obvious, the more total numbers of prescribed medications, the less compliant the patient is going to be. So the key message there is less is more. The fourth point is maybe counterintuitive. And when a patient feels that a certain treatment is more harmful, he's going to adhere more. That seems kind of strange, but I will lay this out, how when a patient comes to you and you feel or you realize that there's a compliance problem, how you can tackle this problem, you or maybe a nurse that helps you during the outpatient clinic. And it is this multimodal approach which the patient continuously makes an evaluation in his head, unconsciously, obviously, and that results in adherence or non-adherence. He will have motivators and barriers, and based on the level of those two, you will see compliance or non-compliance. And those are divided in 5 big, I would say, chapters. The first one is treatment-related factors. If a patient believes his treatment is necessary, if he feels that it's easily manageable, if it's easy to put into the daily routine, then there's going to be adherence. If it's not, then that's a real barrier for the patient. So first try to see, does the patient realize why he's taking the treatment, and is it easy for him to do it every day? The second aspect is disease-related factors. Does he understand what bronchiectasis is? Oftentimes I ask the patient, do you know what you have? Do you know what bronchiectasis is? And often patients have really big problems in understanding what it is. So using drawings and imaging is really helpful there to show the patient what his disease really is. The third point is actually you, the healthcare professional, the trust the patient puts in you, or the easy access the patient has to you or your team, or can pose questions if he has problems. So the good relationship with the healthcare professional is very important. Obviously, there's also personal factors, which is the fourth point. For example, difficulty in remembering treatments or being less motivated. And the last point is the social factors. So a good social network for the patient. What I always do when I see non-compliance is, after the patient leaves and I've given him some more information and maybe adjusted the treatment, that can be possible, I always give a call to the general physician, the general practitioner of the patient, to not only discuss polypharmacy, for example, but also discuss some points that I find are problematic, because the GP is really an important team member of your team in treating the patient with bronchiectasis. And is also very important for the second point, the danger of comorbid conditions. Now, the past few years, we've seen quite a search and research on comorbid conditions in bronchiectasis. And I will just highlight one of them, not yet published, but I think very interesting data on reflux, where we see, and you can see on the left hand here, that patients with reflux disease, gastroesophageal reflux disease, have more exacerbations, significantly more severe disease in terms of bronchiectasis severity index, and both in the St. George's and quality of life bronchiectasis score, a worse quality of life. Interestingly, this trend was not seen in macrolide users. So is it the anti-inflammatory effect or the prokinetic effect of macrolides? That is yet to be elucidated. But nonetheless, I think you need to take into account that reflux is an important factor of comorbidity in patients with bronchiectasis. A second one, which is also in research, and there's going to be data in the next few years, I guess, is osteoporosis. We see that patients with osteoporosis have a more desaturation during the shuttle walk test, who had lower FEV1, higher disease severity, and also accelerated osteoporosis was linked to an increased frequency of hospitalization. And as you can see here in this graph, patients with bronchiectasis have significantly more osteopenia and osteoporosis. Obviously, these are just two examples. We only have 50 minutes, but as you can see here, there's many comorbid conditions. And this is something you need to take into account with the patient. When the patient is sitting in front of you and everything is going well, think about the comorbid conditions that the patient could have. These could be osteoporosis or reflux, but think about nutritional aspects or depression, sleep disorder, diabetes, anemia, etc., cognitive impairment, because all these comorbid conditions need to be well taken care of. And I'm not saying it's your responsibility, because you already have a big job as a respiratory physician to control the respiratory problem, but take a time to talk to not only to the patient, but to the GP, and have a good communication with the GP or the other specialists in treating these comorbid conditions. Why? Because we know that the bronchiectasis etiology comorbidity index, which is the Bucky score, we see that with increased number of comorbidities or increased severity of comorbidities, we see an increase in mortality rate, an increase in hospitality rate, and a decreased survival. So treating these comorbidities is really important. The third point is the context of the patient. You've maybe briefly seen it in the past slides, but socioeconomic status is important. Try to ascertain what the socioeconomic status of the patient is. Is he in a difficult financial situation? Which is important to know, because these patients have a chronic disease. They need lots of medication, which often cost a lot of money. So it's important to realize and to discuss with the GP how the situation at home is with this patient. Often it only takes once to do this discussion with the GP, and then you know where to go from there. Don't have to do it every time the patient comes to your cabinet. And the second point is something I really I'm interested in, and that's air pollution. And here you can see that with increasing air pollution, the risk ratio of having an exacerbation at day 0, which means that 24 hours before the exacerbation, is really high. So pollution really is a subacute to an acute effect of increasing your risk for having an exacerbation. Why am I telling this for the National Society of Italy? Because as in Belgium, both Italy and Belgium, we are both champions in air pollution. Fortunately, if we compare it to the data of 10 years ago, it's getting better, but still we need to take this into account, certainly for the northern part of Italy and the region of Milan. With the data that you see here, you see a very good decrease in air pollution, but that's because of the corona virus epidemic and the isolation that was called out. But in Milan, you would say with the second wave that we now have, is it still lower, the air pollution? And as you can see, the first wave here, if we compare it with 2019, there was actually a lower air pollution levels. But if we compare the last few weeks, you can see that there's almost no difference. So be aware of air pollution. And I often have patients who tell me that they feel much better when they go somewhere where there's less air pollution. So for Belgium, they often go abroad on vacation in Spain and Portugal, which they feel is better for their lungs. The fourth point, penultimate point, is the essence of chest physiotherapy. And I can't emphasize this more. It is of primarily an essence for the patient as a first treatment of bronchiectasis, because it tackles the vicious vortex. It tries to disrupt this vicious vortex of epithelial dysfunction with mucus hypersecretion and ciliary dysfunction, then going on to cause inflammation, destruction, and chronic infection. Here you can see a normal cilia with normal mucus on top of it, and this is Pseudomonas aeruginosa infecting the cilia and causing disruption of the ciliary beat frequency. You will hear much more on cilia in the next talk, but I just want to briefly point out that when a patient has a strain of Pseudomonas aeruginosa, that strain will produce pyocyanins, for example, decreasing the ciliary beat frequency. And what happens, not only because of the bacteria, but also because of the inflammation, you will have neutrophil elastase, you will have these pyocyanins, and you will have a decreased ciliary beating and stimulation of mucin secretion. And this will then cause a dehydration of the mucus layer and an osmotic imbalance between the mucus layer and the periciliary layer. And this osmotic imbalance will then cause a compression of the cilia, and because the cilia beating is slowed, there's going to be mucus adhesion, and there's also be an enhanced accumulation of mucus. And the only way to overcome this or to expectorate at this point, because the cilia are not working properly, but you need to get rid of the mucus, obviously, is to cause a peak expiratory flow that should be greater than the peak inspiratory flow by at least 10% for the mucus to move proximally. So just doing sports is not enough. You need to do the special chest physiotherapy techniques. And also the peak flow should be 30 to 60 liters per minute to break these adhesive bonds that are generated between the mucus layer and the epithelial surface. The technique you're using does not really matter that much, autogenic drainage or the open glottis technique or some positive expiratory pressure techniques, as long as you're doing something that helps expectorate the mucus that is retained in the lungs. And then finally, one of my personal favorites, the wonder of hypertonic saline. And I will have to admit, there's not a lot of data in clinical studies, but in my clinical practice and experience, I find that patients really are benefiting from hypertonic saline. These two small studies, and there's a third study that I haven't put on there on the slides, show that there is a improvement not only in quality of life of the patient using hypertonic saline, but you will see also a improvement of lung function indices and also an improvement in annualized exacerbations and annualized antibiotic use. And up until recently, I had to motivate my colleagues to use hypertonic saline when chest physiotherapy isn't enough. And more recently, there has come another great letter to the editor with some extra motivation to start hypertonic saline. As you know, 5 to 10% in Europe and much larger numbers in the US of bronchiectasis patients have mycobacteria infection. And this is a brilliant paper showing that if you used hypertonic saline versus growth control in avium, you will see that with increasing saline concentrations, you will see that the colony forming units are being halted. So the growth is being halted. And for abscesses, which is obviously a more dangerous species of mycobacteria, you will see that it is only the case for the hypertonic saline of 6%. So this is another argument to when your patient has difficulty to expectorate the mucus, even when he's using the physiotherapy, try to add hypertonic saline, so 6% or 7%, 4 drops, 5 drops of salbutamol or 2 puffs before you start inhalation, and then afterwards you do the expectoration with the techniques that you have been learned by the chest physiotherapist. And finally, an overview of the 5 points. So first and foremost, try to think about the difficulty of treatment compliance and the danger of comorbid conditions and the context of the patients. When you have assessed all these 3 key points, try to communicate with the general physician of the patient to tackle some of these. You don't have to do it all by yourself, obviously. Then think about the essence of chest physiotherapy. It's really the basis of treatment for bronchiectasis patients. So call the physiotherapist if you're in doubt, because he's the man or the woman who will see the patient twice a week, once a week, 3 times a week. He knows the evolution much better than you. And then finally, if it doesn't get better, try to think about hypertonic saline. And I've deliberately not talked about macrolides, but I guess the questions will ask something about that. Thank you so much.
Very good, Peter. Thank you so much for the great overview. I think that ideally we should have the discussion at the end, but if there is any impellent question, please write down on the chat and we will ask him. In the meanwhile, Peter, you talk about GP a lot. There's no GP active in the Embark network. there's nothing we have done so far as I know, but you can correct me, to strengthen the relationship between GP and secondary care. We don't have any relationship in the bronchiectasis management, the tertiary care, with our GPs. So if you have any experience, local experience of standard operating procedures or a pathway of management with your GP, can you share this with us?
Yeah, so fortunately, there's one GP that helped us with the guidelines back in 2015, I think, or 17, I think. So there was one GP from Scandinavia who helped us out. But you are absolutely right. We should more include GPs. What I do when I have a patient and the patient leaves the cabinet and I need to discuss something with the GP, we have in our electronic system always who is the GP and the telephone number of the GP, so I can easily call the GP. And in Belgium, GPs are really easily accessible. If you cannot access the GP through telephone, there is an app called Silo. Maybe you know it as well. Sometimes that's a locked app, SIILO, which is used between doctors in Belgium to share information in a private way, in a private manner, and to discuss certain patients over. When you don't have time to make the call and you do it later, you can discuss this through it. It's a sort of a WhatsApp, but it's very, very well taken care of in terms of privacy and security. So that's also an alternative.
Thank you
so much, Peter. So please,
if I had a comment to this, the answer of Peter, that we really realize that you in Belgium are much more organized on this profile, because in Italy we have a big gap on this in this kind of organization, and this is also coming out very clearly during the pandemic, because there is a clear there is not an organized network of GP that are very crucial, above all in chronic disease and in interaction with specialists in the hospital. So I congratulate. I knew that Belgium is much more organized. This is one comment, because it's a very, for us, it's a very big problem.
So what you could do when the patient comes into your outpatient clinic is ask the nurse to ask the patient who is his general physician, and then on the internet you can always find normally the number of the general physician and note it down, and then once you have the number, you can put it in your own phone. I have a lot of GPs, their number in my phone, so I know when to call them. And so this is something the nurse can do. You don't have to do it yourself. When the patient comes in, just ask who is the GP and then write down the number, and you can later call him if necessary. It's not always necessary, but sometimes it is.
No, but okay.
Thank you, Peter. If you have any question, please write on the chat, and we will ask Dr. Kruming at the end of the presentation. Now, it's my pleasure to introduce Amelia Schumacher. She's a very well-known expert in PCD, in primary ciliary dyskinesia. I had a chance to work with her over the past few years, and I'm really honored to work with you, Amelia. You are really a mentor for us in the field, and thank you for giving us this lecture, which is a lecture specifically on the suspicion and diagnosis of PCD in adults with bronchiectasis. So a different perspective, but I think that it's a really interesting topic from all of us that are working as pulmonologists in the bronchiectasis clinic. Thank you so much, Amelia, for being with us tonight.
Thank you, and thank you for inviting me to speak. My screen is shared, which is great. And we'll just great. So yes, I'm going to talk about the diagnosis of primary ciliary dyskinesia in adults with bronchiectasis, as Stefano says. I'm a researcher at the University of Dundee. I have spent 20 years at the Brompton Hospital in London as a diagnostic scientist making diagnosis of primary ciliary dyskinesia. And I'm also chair of the Beat PCD network, which is a European Respiratory Society clinical research collaboration, which has newly been formed. So we are trying to follow in the footsteps of Embark, but for PCD. So I just wanted to start off with what is primary ciliary dyskinesia. I think in the past we've always thought of it as a single condition, and actually as our knowledge of genetics has improved over the years, and this slide sort of shows the first gene which was identified in 1999, and now we are up to about 50 genes, a mutation in which can cause PCD. We're really beginning to see it more as a group of inherited disorders of motile cilia function, and there's subtle differences in genotype and phenotype. But patients, of course, have some commonality in terms of symptoms related to the dysfunction of the cilia. And it is usually inherited in an autosomal recessive way, but some of these new genes that have been identified in 2019, 2020, they are also X-linked inheritance and also dominant inheritance, so the spectrum is increasing. So to think about what PCD is really, these are the cilia, so thank you, Peter, so much for the introduction of why cilia are so important in bronchiectasis in the airway. And this is from a nasal brushing from Control. I don't know if you recognize that nose, but it is mine. These are the cilia moving in a backwards and forwards sweeping motion to clear the secretions out of the airway. This is a typical patient with primary ciliary dyskinesia in which the cilia, they do not move at all, and therefore the secretions aren't cleared, and it really impacts infection and the accumulation of mucus in the airways. They are not always static, they don't always completely immotile, so this is looking at normal cilia from the top down, and you can imagine a mucus particle here would clear and be expectorated from the airways. This is another patient with primary ciliary dyskinesia in which really the beating is just disorganized. So we've moved on from seeing it as an immotile cilia syndrome and more into a series of conditions in which the cilia are not infected due to, are not effective due to a genetic cause. So cilia are present in many areas of the body. They start in the inferior turbinate of the nose, and they line the respiratory tract. And as a result, as the cilia conditions begin at birth, where most patients suffer from some neonatal respiratory distress because the secretions aren't cleared from the airway effectively at that time. Patients then get a wet and productive cough, productive of sputum, and suffer from recurrent chest infections throughout childhood as the cilia fail to clear secretions, ultimately resulting in bronchiectasis. And most children, by the time they reach adulthood, have bronchiectasis. Because the cilia line the upper airways as well, then most patients will have chronic rhinitis and some sinusitis, although in some of our genotype-phenotype studies, we're beginning to find that this is less associated with certain gene mutations like DNH11. In childhood, children will get recurrent otitis media that often will resolve by the time the patient presents in the adult clinic, but some children do end up with severe persistent hearing impairment, which can be seen in adults with bronchiectasis and PCD. The cilia are also active in the embryonic node during development, and therefore patients get, or 50% of patients approximately get situs inversus, as those cilia fail to do their job in determining left-right symmetry. And then there are other features which are associated with the condition much more rarely, but there are cilia in the brain, and therefore people get hydrocephalus who have PCD very rarely. It's a real problem for some of our experimental research, because some of the animal models frequently die of hydrocephalus. It's also associated with retinal abnormalities such as retinitis pigmentosa. That's usually specific genes, and also congenital heart disease. About 12% of patients have other heart defects beyond situs inversus. Oops, sorry, I animated this. So thinking about PCD as a cause of bronchiectasis, this is the EMBARC registry, which I think people are familiar with. Just to say that now in the EMBARC registry there are over 18,000 patients, and 350 of those patients with bronchiectasis have PCD, and that makes up about 2%. So it's quite a small percentage of patients with bronchiectasis. I'm hoping I will be able to convince you that I think that is probably underdiagnosed and that we are not spotting it. We're missing it in our bronchiectasis clinics, and that's a shame because the diagnosis can be important. So what do those 350 patients we do know about, what do they look like? They tend to be younger than other patients in our clinics. The sex is similar in terms of seems to be a bit of a female bias. Importantly, lung function is worse than their counterparts with idiopathic bronchiectasis. And even if you match for age or infection, the lung function remains worse. Daily sputum volumes are much higher. And importantly, there's really a large percentage of people with PCD are growing Pseudomonas aeruginosa, which we know are bad. It's also associated with an increased frequency of exacerbations, even once you've adjusted for the presence of the Pseudomonas and for the severity of disease. PCD patients are still having more exacerbations per year and more hospitalizations per year than other bronchiectasis patients. And then this is looking at the data. This isn't longitudinal data, but the age of enrollment at the EMBARC registry. And you can see that patients with PCD really are doing worse than our other idiopathic bronchiectasis patients when you look at their lung function. So hopefully, I have convinced you with some of that data that patients with PCD and bronchiectasis are at risk of severe disease and are at risk of exacerbations, and being able to predict that is important. So a diagnosis is important. Very in line with what Peter was saying about comorbidities, it's a multi-system disease affecting lots of different organs, and therefore a diagnosis is important because there may be a requirement for ENT and for cardiac defects. One thing we didn't talk about previously was fertility, and because the cilia structure is very similar to the sperm tail structure, some males with PCD are infertile, and that is genotype specific, so that is not always the case, but sometimes the case. Because it's a genetic condition similar to cystic fibrosis, then genetic counselling is also a requirement for patients once they are diagnosed. And then access to treatment and health services can sometimes be impacted by having a diagnosis depending on what country you're in. Certainly in the UK, there is now, as of this year, a specialist PCD management centre. So if you have a diagnosis of PCD, you come out of the general bronchiectasis clinic and go into the specialist management centre, where there is more support and funding for things like IVs. And in the future, because it's an inherited condition, a little bit like cystic fibrosis, we are far behind, but there may be PCD-specific therapies. There are certainly messenger RNA and gene-related therapies which are in the pipeline very early on in preclinical trials at the moment. But these things are evolving increasingly as time goes on. So why do we think that PCD is underdiagnosed in the adult bronchiectasis clinic? I just wanted to share a little bit of this data, which is from the 100,000 Genome Project, which was a UK project where 100,000 people had whole genome sequencing. It was a big deal for the government at the time. They were very excited about it. And PCD was a disease that was put into that group, but also bronchiectasis patients who were thought to have inherited bronchiectasis were also recruited. So if a physician thought that their patient had PCD, they recruited in the PCD domain. If they thought they had bronchiectasis, which wasn't caused by PCD but was inherited, they were recruited into the bronchiectasis domain. And interestingly, doing the whole genome sequencing on these patients, there were 141, so small numbers, but 141 bronchiectasis patients recruited, and 15 of those thought not to have PCD or had PCD mutations, so 11% of those bronchiectasis patients. Incidentally, the PCD solving rate was about 80%. And then we also, just to validate that in a different cohort, at the Brompton Hospital, we have a clinical panel. So we have a bronchiectasis panel, and we also have a PCD panel. And it is a specialist centre that does PCD diagnosis, so it is not difficult to refer. But again, just looking at people who were referred due to bronchiectasis and all PCD referrals excluded, 6 of our 56 patients referred to that panel also were found to have biallelic mutations in a motile ciliopathy gene, so essentially to have PCD. So I think it's being missed even in places where there's quite a lot of workup. And therefore it's likely that taking into account not even sending for testing, that PCD is much more prevalent than thought. So when to suspect a diagnosis, I think from the EMBARK data, we can say patients who present to the clinic when they are young, people who present with severe disease and Pseudomonas, people with a childhood history of infection, and associated features such as infertility, other features of other ciliopathies like cystic kidneys, developmental delay, retinitis pigmentosa, obviously patients who have situs inversus and congenital cardiac defects, and also people with coexisting upper airway disease and otitis media. So what do we do when we do suspect a diagnosis? There is a predictive score which was published a few years ago. This was clearly worked up in people working with children rather than people working with adults, and many of the questions are about early life. So was the person born preterm or full term, which I appreciate some of our patients won't know or won't be able to get that information, and also about chest symptoms in the neonatal period, admission to a neonatal unit, situs abnormalities, congenital heart defects, persistent rhinitis, and then also the chronic hearing symptoms. And people with more than 5 points on this scale should be referred for PCD diagnosis. What next? So if you have a patient with a good clinical history, and what is next in the diagnostic pathway? Well, the first test to do is nasal nitric oxide, and this is a child, but it's the same for adults. You use a chemiluminescence analyzer to measure the nasal nitric oxide, and many pheno machines that people have in their clinics can be converted to do this. There is the nasal nitric oxide is produced in much higher amounts than the pheno is. It's more like hundreds and thousands of parts per billion, but it is internationally recognized that it's reported in nanoliters per minute because it depends on the flow of the machine. I've just put a table up here which compares studies where bronchiectasis has been compared to PCD. Most just compare PCD to healthy controls or CF, but there are some studies where bronchiectasis is compared to PCD, and nasal nitric oxide really is a good indicator. So patients with PCD have a low value, and this is all traced from our machine here, where the person breathes in and out, and as they hold their breath, really nothing happens with the nitric oxide if you have PCD. One of its biggest problems is it can't be used in small children, which is really, as a field, when we want to make the diagnosis, because that's when we can do the most to stop progression of disease. But for adults, it's a fantastic test. There are patients who have normal nasal nitric oxide, so if the clinical suspicion is high, then it is not good to stop there with this screening test. And there are some genes which are known to be associated with that. And equally, people can have low nasal nitric oxide and not have PCD. So smokers, obstruction, if you used it as a screening test for the general population with no pre-test probability, it would be a terrible, terrible test. So it does have its limitations, and therefore we do go on to do further testing. So how do you confirm a diagnosis? Well, by a recognized transmission electron microscopy defect or a biallelic mutation in a known PCD gene. And I'm really pleased to say that for these EM defects, that we have now reached an international consensus on what constitutes a diagnostic defect and how to report these. And that was met by 18 centers in 14 countries. And Italy was represented by the University of Siena. 30% of PCD patients, though, have a normal electron microscopy defect or subtle abnormalities in ultrastructure. So we definitely cannot do electron microscopy alone. The genetics is fascinating. So as I said at the start, we have 50 different PCD genes. This is just looking at our clinic of 263 patients in collaboration with Hannah Mitchison. If we apply a gene panel model, then we can solve about 72% of those patients. We have new novel candidate genes that are yet to be reported, so that is an improvement. Some patients have a mutation in a single allele, but not a second mutation. And then there's some patients who clinically we are really sure have PCD, or even by electron microscopy are sure have PCD, but we cannot make the diagnosis. And if you think about it in terms of something like cystic fibrosis, where there are lots of different variants within the CFTR gene, but lots of, most people have a delta 508. PCD, 77% of our patients have private mutations. So they have a variant within a PCD gene that's never been described before in another patient. And as part of Beat PCD, one of the things that we are doing is collecting all of these variants, but there are thousands. So there are 50 genes and hundreds of variants within each gene. So it's not very simple to make a genetic diagnosis, but it probably is the future. And so again, about 30% can't be saved by EM, and about 30% can't be solved by electron microscopy. So high-speed video, as I introduced at the beginning, is another modality, and this is just another example of a PCD patient with some dysfunctional cilia. And really that is the root of the condition, is the cilia not clearing properly and not moving properly. So if you can actually visualize that, that is another way to make a highly likely diagnosis if you do this several times and the cilia are not effective at clearing and moving. And then a new test that is coming on board is immunofluorescence, which is using proteins labeled against key parts of this cilium and to see whether they're present or absent. And I'm sure that will be in the next guideline as a test to do. It's simpler than electron microscopy, and it's also a good way to validate some of these gene defects. If you get two variants of unknown significance, being able to actually look at the protein in question and see whether it's present in the cilia in the patient is a good way to be able to confirm that variant or not. So I just wanted to quickly touch on some improvements in diagnostic testing, because I think gene discovery continues, and just this year we've had more PCD genes described and identified, and I think that will carry on. But also electron microscopy really is improving as well, and this is just this is a picture from the cover of Cell this year. This is just one of those single microtubules, so one of these little bits up here, and this is Alan Brown, and they have described all of these individual proteins within the microtubular doublet, and 3 at least of those, if not more, are proving to be PCD genes, so NME7 and NMS1 and MKS. So really the detail that we're able to see with electron microscopy in a research setting is improving massively, and gene diagnosis in a research setting is improving massively, and I think clinically that will catch up quite quickly in being able to solve many more cases. So in summary, PCD is an inherited cause of bronchiectasis, accounting for 2 to 12% of cases. I personally believe it's more at this higher end. It's often underdiagnosed in childhood and especially in adults. Diagnosis currently is a multi-test process and should include nasal nitric oxide, high-speed video, EM, and genetics. And it's also important that diagnosis is made to provide appropriate care and counselling to the patients. And these are just thanks to all of the people that I work with in Dundee, in London, and the international consortia and people whose work I've talked about in this presentation.
Thank you so much, Amelia. Thank you for the great presentation. I see some question in the chat, so I would like to summarize this. The bronchiectasis disease is a very heterogeneous in terms of etiology and clinical presentation and response to treatment. PCD is very heterogeneous. So we have two diseases that are really heterogeneous, and these make the diagnosis of adults with bronchiectasis very, very difficult. You mentioned all the different tests, and people are asking something about the role of genetics within the flowchart of the diagnosis of PCD in adults. So we have some guidelines suggesting the very nice flowchart for the diagnosis of PCD. But what we really need is to individualize those flowcharts in a patient with bronchiectasis. Can you give us some suggestion about that, Amelia, please?
I totally agree, because I think at the moment, especially the current guidelines were written very much mainly by pediatricians, and the perspective maybe of coming from a patient who is already an adult with bronchiectasis is not maybe represented as well as it could be in those guidelines. And also, it's now been a number of years since those guidelines have been written, and the genetics has improved markedly. We've learned a lot more, I think, about genetics. It's still, I think, if you really want to diagnose all of your patients, you still need to use all of the tests. But certainly. Nasal nitric oxide does form a good test to be able to at least exclude some people with a poor history, and genetics, as it gets cheaper and more accessible, especially in places where there's not an electron microscopy lab or the high-speed video is not possible, I think should come higher up the flowchart than it currently is, where I think when we wrote the guidelines, there was really no evidence, because nobody had done any studies to look at if you had a group of people, would a genetic diagnosis be specific or sensitive? And I think that's still difficult to do, because people only test people are confirming a diagnosis by genetics, but there's not been very many studies looking at who is being missed with using genetics, because that's difficult to do.
Yeah, and I was thinking about, what's the role of the MDT, the multidisciplinary team, in making the diagnosis of PCD in the adults with bronchiectasis? And anyone suggested a possible classification of definitive PCD diagnosis in bronchiectasis versus probable or possible PCD diagnosis of bronchiectasis? What is the state of the art in this field?
So I think the state of the art is, so if you have an EM or a biallelic gene mutation, then certainly it's a definite diagnosis. But you could also have a highly likely diagnosis from doing high-speed video and seeing that is repeatedly abnormal, but not finding an EM or gene defect. It's also possible to use a kind of cell culture techniques where you grow the cells so that you have removed any secondary infective or inflammatory stimulus, and therefore all changes you see, you are more convinced that they are primary, even if you can't find a gene. But I'm sure we all have patients in our clinics who we have high clinical suspicion and maybe not access to the tests or inconclusive results from the test, which are frustrating, who certainly in things like the IPCD cohort, which is the one of the international registries, they are still included within that, but as a highly likely or as a likely PCD rather than a definite diagnosis. So we still use that data in our research studies, and certainly you might want to treat the clinical symptoms anyway.
Yeah.
Okay.
So Amelia, thank you so much for the great talk and for being with us tonight. And was a great discussion. E ora ridarei la parola alla professoressa De Rose per l'ultima relazione. Grazie mille.
Thank you.
Grazie Stefano. Allora passiamo all'ultima relazione, che sarà presentata dalla dottoressa Sant'Ambrogio, che lavora al Policlinico di Milano. Il titolo è Strategie di disostruzione bronchiale e di allenamento nei pazienti adulti con bronchiectasie. Prego, dottoressa Sant'Ambrogio.
Buonasera a tutti, spero che si veda bene lo schermo. Grazie mille per l'invito. Adesso andiamo a trattare in quest'ultima parte appunto gli aspetti relativi alla fisioterapia nei pazienti adulti con bronchiectasie. Ci concentreremo in particolare sulla disostruzione bronchiale e il riallenamento allo sforzo. Dunque, questo è un qualcosa di cui abbiamo già accennato anche nelle relazioni precedenti. Le bronchiectasie sono caratterizzate da una grande eterogeneità sia in termini di eziologia che in termini di presentazione clinica, e quindi abbiamo una varietà di segni e sintomi che caratterizzano questa patologia. Alla luce di questa eterogeneità è importante che il trattamento di questi pazienti sia un approccio di tipo multidisciplinare, e in questo approccio multidisciplinare la fisioterapia respiratoria trova un ruolo chiave, perché è dimostrato che è in grado di ridurre i sintomi, la frequenza delle riacutizzazioni e migliorare la qualità di vita dei pazienti. Come potete vedere in questo bel grafico, il ruolo dei fisioterapisti evidenziato nelle parti colorate in blu è abbastanza trasversale a diverse problematiche dei pazienti bronchiettasici, e quindi diciamo che la fisioterapia trova proprio un ruolo chiave nel trattamento di questa patologia. Quando parliamo di fisioterapia in bronchiettasie, diciamo che possiamo identificare 4 grosse categorie di interventi: degli interventi di tipo educazionale e rivolti al self-management del paziente, degli interventi di disostruzione bronchiale, interventi rivolti all'esercizio fisico, quindi riallenamento allo sforzo di tipo endurance oppure rinforzo muscolare, e degli interventi di management dell'ottimizzazione della terapia inalatoria, ma anche di altre terapie, quali ad esempio l'ossigenoterapia o la ventiloterapia per i pazienti che ne hanno bisogno. E oggi ci concentreremo soprattutto su i 2 interventi di disostruzione bronchiale e riallenamento allo sforzo. Allora, quali sono i pazienti, i soggetti candidati alla fisioterapia, in particolare alla disostruzione bronchiale? Come potete vedere da questi estratti di linee guida, i soggetti che beneficiano, per i quali è consigliata la disostruzione bronchiale, sono i pazienti ipersecretivi o quei pazienti che hanno delle difficoltà ad espettorare un grosso ingombro di secrezioni, o ancora quei pazienti che generalmente in fase di stabilità non presentano grosso ingombro bronchiale, ma che invece vanno incontro ad ingombro durante le fasi di riacutizzazione, per cui è importante che conoscano una tecnica adeguata di disostruzione bronchiale da utilizzare ad hoc nei momenti delle riacutizzazioni. Qual è l'effetto della disostruzione bronchiale? La disostruzione bronchiale serve per facilitare il trasporto del muco e l'espettorazione, migliorare la ventilazione, ridurre le resistenze delle vie aeree, correggere eventuali alterazioni nel rapporto ventilazione-perfusione e quindi ritardare il peggioramento del danno polmonare. Diversi studi hanno dimostrato un effetto delle tecniche di disostruzione bronchiale rispetto al non trattamento o a delle tecniche placebo nel aumentare appunto la quantità dell'espettorato, ridurre i sintomi, migliorare la qualità di vita. Alcune tecniche sono anche in grado di migliorare la qualità dell'espettorazione, perché il paziente è in grado di espettorare una maggior quantità di secrezioni in un determinato momento della giornata in cui svolge le sedute di disostruzione bronchiale, quindi avere un certo numero di ore libere da muco e da sputo, e quindi un miglioramento della qualità di vita anche in questo caso. Esistono diverse tecniche di disostruzione bronchiale. Ad oggi non ci sono dei dati chiari di una superiorità di una tecnica rispetto ad un'altra. Quindi, alla luce di tutte queste tecniche che esistono, quali tecniche sarebbe meglio utilizzare? Degli studi abbastanza recenti hanno confrontato tecniche strumentali che utilizzano pressione positiva con tecniche che non utilizzano pressione positiva, e anche in questo caso non è stata trovata una differenza significativa tra le diverse tecniche in termini di miglioramento della qualità di vita dei pazienti, miglioramento dei sintomi, quali ad esempio il sintomo di dispnea, e miglioramento delle funzioni della funzionalità polmonare. È vero che questi studi sono tutti studi con dei campioni relativamente piccoli, dove è difficile fare un vero e proprio confronto tra le tecniche, anche perché spesso le tecniche di fisioterapia respiratoria sono specifiche e individualizzate sul paziente. Se andiamo a vedere i dati, qua ho riportato i dati dei registri di bronchiettasia, abbiamo quello europeo, EMBARC, quello indiano e quello statunitense. Più o meno il 50% dei pazienti che appartengono al registro utilizza tecniche di disostruzione bronchiale in fase di stabilità. È interessante osservare come le tecniche più utilizzate in ambito europeo non sono le tecniche più utilizzate in ambito statunitense, ma questo può essere legato anche a delle scelte specifiche di appunto terapia individualizzata sul paziente. Quindi, alla luce di questi dati, che cosa si fa con i pazienti quando si fa disostruzione bronchiale? L'obiettivo è essere in grado di modulare i flussi e i volumi, quindi modulare i volumi per generare dei volumi e ottimizzare la ventilazione regionale. Questo si può fare con diverse tecniche, sia strumentali, come ad esempio le tecniche a pressione positiva, che tecniche non strumentali, come l'adottare determinate posture, l'inspirazione lenta e profonda o l'apnea teleinspiratoria. Oltre a generare dei volumi, è necessario generare e aumentare il flusso espiratorio per poter mobilizzare le secrezioni in direzione prossimale, e anche in questo caso esistono diverse tecniche che permettono di generare questi flussi espiratori in grado di muovere le secrezioni. Quindi diciamo che non esiste una singola tecnica perfetta, ma esistono delle sedute di disostruzione bronchiale in cui le diverse tecniche vengono mixate e combinate, e le diverse strategie vengono appunto combinate per ottenere un'adeguata clearance delle vie aeree. È importante sottolineare come si possano utilizzare anche in casi specifici dei trattamenti coadiuvanti. C'è poca letteratura in merito, però diciamo che le linee guida in questo ci aiutano. I trattamenti coadiuvanti servono in casi specifici in cui si osserva appunto la necessità di aiutare il paziente nelle tecniche di disostruzione bronchiale. Trattamenti coadiuvanti possono essere, per esempio, il trattamento con la soluzione ipertonica, di cui abbiamo già parlato prima, nel caso di secrezioni dense e tenaci, o l'utilizzo anche di un'umidificazione attiva, sempre per questo scopo, l'utilizzo di farmaci broncodilatatori per i pazienti che ne abbiano bisogno e anche l'utilizzo di ventilazione non invasiva per quei pazienti che possono avere difficoltà ed eccessiva fatica durante le tecniche di disostruzione bronchiale. Quindi, come fare a scegliere una tecnica adeguata? La prima cosa importante è valutare e fare un'analisi critica dei pazienti, del paziente che ci troviamo davanti nella determinata condizione clinica in cui ce lo troviamo davanti. Questo per valutare tutti i vari aspetti, quindi gli aspetti legati allo specifico fisiopatologico del soggetto, come ad esempio le proprietà delle secrezioni, se ci sono secrezioni troppo tenaci, l'eventuale broncocostrizione, la mancanza di fiato, l'eccessiva fatica del paziente durante la tecnica, ma anche aspetti non prettamente fisiopatologici, come la collaborazione del paziente, o le preferenze del paziente. Da non sottovalutare il fatto che poi la tecnica è una tecnica che il paziente dovrà utilizzare a casa sua e quindi che è importante che sia un trattamento valido anche al di fuori delle mura dell'ospedale, e l'aspetto economico. Ci sono dei trattamenti che sono più cari e che non sempre sono, le cui spese non sono sempre coperte dal sistema sanitario nazionale, e quindi anche valutare l'impatto che la scelta della strategia di disostruzione bronchiale può avere dal punto di vista economico. Quindi, riassumendo, le tecniche di disostruzione bronchiale devono essere individualizzate e specifiche per ogni paziente in una specifica condizione clinica, quindi non è detto che con l'evolvere della patologia o che in condizioni diverse queste tecniche siano sempre valide, e possono essere un mix di diverse strategie per andare a rispondere a tutte le problematiche del paziente che stiamo trattando. Come detto prima, la disostruzione bronchiale trova una sua applicazione nel paziente bronchiettasico ipersecretivo, ma anche nel paziente in fase di riacutizzazione. Ci sono pazienti che in fase di stabilità non hanno un'eccessiva produzione di secrezioni, ma che invece nel momento della riacutizzazione necessitano di impostare un trattamento con disostruzione bronchiale, oppure pazienti che modificano le loro tecniche di disostruzione bronchiale tra la situazione di stabilità e la situazione di riacutizzazione. E in questo caso quindi appare molto importante il follow up, perché non sempre il paziente viene valutato in una fase di riacutizzazione, ma è importante che le riacutizzazioni vengano trattate correttamente anche dal punto di vista della disostruzione bronchiale e della fisioterapia respiratoria. Ci spostiamo adesso sulla, seconda parte di questa chiacchierata, quello che è l'esercizio fisico nelle bronchiectasie. Allora, esiste un'indicazione a svolgere esercizio fisico nei pazienti bronchiettasici. La riabilitazione polmonare è un intervento complesso, quindi non include soltanto l'esercizio fisico in quanto endurance training e esercizi di rinforzo, ma comprende anche una parte di interventi educazionali e una parte di cambiamento dello stile di vita dei pazienti. Come si fanno queste sedute? C'è la possibilità di svolgere sedute sia, che i lavori che si trovano in letteratura sono vari, per cui ci sono delle sedute, dei programmi che vengono svolti all'interno degli ospedali, dei programmi che vengono svolti in modalità ambulatoriale, e stanno prendendo sempre più piede anche i trattamenti in teleriabilitazione, telemedicina, che nella situazione sanitaria attuale possono avere un certo interesse. Non c'è niente in letteratura sui pazienti bronchiettasici, ma può essere uno spunto per il futuro. In che cosa consistono le attività in cosa consiste l'esercizio fisico? Abbiamo detto 2 grossi capitoli: endurance training e esercizi di rinforzo. Come potete vedere da questa tabella, qui sono riassunte alcune, diciamo, possibili modalità in cui si possono impostare endurance training e strength training. Non sono le uniche. Quello che è importante è tenere a mente che il percorso il programma di esercizio fisico è un programma molto specifico e che prevede che vengano proprio specificati e, diciamo, concordati con il paziente la modalità in cui questo programma viene svolto. Quindi una specifica tipologia di esercizio, che sia un esercizio continuo, intervallato, a seconda poi di quello che viene valutato dal terapista, la durata della seduta, la durata del programma, la frequenza con cui il paziente settimanalmente deve svolgere le sue sedute, la resistenza, sia in termini di resistenza o velocità se il paziente si allena camminando, o carico se parliamo di esercizi di rinforzo muscolare, e anche le modalità in cui questo programma verrà poi trasformato in un programma di mantenimento, quindi quello che sarà il programma di mantenimento. I dati della letteratura ci dicono che l'esercizio fisico sembra essere efficace nei pazienti bronchiettasici, sia dal punto di vista degli outcome, diciamo, diretti, quindi un incremento dei metri percorsi al test del cammino, un miglioramento della distanza ottenuta all'incremental shuttle walking test, ma anche un incremento della qualità di vita, una riduzione della sensazione di fatica muscolare e di dispnea sotto sforzo e una riduzione delle riacutizzazioni. Ultimo aspetto, sempre relativo al capitolo esercizio, è l'attività fisica. Qui si tratta di attività fisica, diciamo, non esercizio fisico, quindi attività fisica vuol dire vita meno sedentaria, vuol dire qualsiasi tipo di attività che viene fatta dal paziente, anche in una maniera non precisa, specifica, regolata e concordata come l'esercizio fisico. Non ci sono dei dati precisi in letteratura sull'efficacia dell'attività fisica specifica nel paziente bronchiettasico, però, come potete vedere da questo grafico, il paziente bronchiettasico, qua è in verde, sembra avere un'attività fisica ridotta rispetto ai controlli sani, sia in termini di numero di passi al giorno che in termini di quantità di attività fisica moderata e vigorosa misurata come minuti al giorno, e quindi è consigliabile comunque diciamo implementare in qualche modo, fare degli interventi anche di tipo educazionale per implementare l'attività fisica nei soggetti bronchiettasici. Per chiudere, qualcosa di cui si è parlato anche diciamo all'inizio di questa chiacchierata, gli interventi educazionali hanno un ruolo fondamentale, un po' trasversale nella gestione del paziente bronchiettasico, quindi non è qualcosa di pertinenza solo del medico, solo del fisioterapista, ma attraversa un pochettino tutti gli interventi e tutta la presa in carico del paziente bronchiettasico. E l'intervento educazionale è importante per favorire l'aderenza del paziente, aumentare soprattutto quello che riguarda il cambiamento dello stile di vita e aumentare anche il self-management del paziente, che dovrebbe essere in grado di riconoscere i sintomi e di adottare azioni e strategie nel momento in cui questi sintomi si modificano. In conclusione, le bronchiettasie sono una patologia eterogenea che richiede quindi un approccio multidisciplinare e un trattamento che sia specifico e individualizzato anche in termini di fisioterapia respiratoria. È importante quindi adattare le tecniche di fisioterapia respiratoria per ogni paziente e alla luce del cambiamento della situazione clinica e delle condizioni cliniche del paziente. Facilitare degli stili di vita, diciamo, sani e dei cambiamenti negli stili di vita dei pazienti, e facilitare anche l'autotrattamento del paziente dove possibile. E diciamo che in ambito di fisioterapia respiratoria sicuramente ci sono tante tematiche ancora aperte che potrebbero essere tema di future ricerche. E con questo ho concluso. Volevo giusto ringraziare i colleghi e il team in cui lavoro, e ancora una volta per l'invito a questa chiacchierata. Grazie a tutti.
Grazie Marti. Adesso aspettiamo che si colleghi anche la professoressa De Rose, e intanto permettimi di ringraziare te e tutti i colleghi fisioterapisti per il costante lavoro che fate tutti i giorni sul programma. Siete veramente l'intervento più importante su questa malattia. Per cui grazie mille. Lascio la parola alla dottoressa De Rose.
Pensavo di essere collegata, in realtà c'è stato un problema tecnico. Comunque ringrazio anch'io la dottoressa Sant'Ambrogio per questa revisione completa dell'approccio fisioterapico a questi pazienti, e quindi vedo qui che sulle chat non mi sembra che ci siano domande specifiche. Per la dottoressa Sant'Ambrogio faccio io una domanda e un commento. Lei ha accennato giustamente al problema della telemedicina, che oggi ovviamente nell'era digitale diventa un'opzione sempre più perseguita sotto molteplici diciamo profili e aspetti, e naturalmente quello della fisioterapia potrebbe essere uno di questi, in particolare nel telemonitoraggio diciamo dei pazienti dopo un training adeguato, e in particolare ritornando al gap che noi abbiamo con diciamo l'organizzazione territoriale, al fatto che naturalmente ovviamente faciliterebbe l'approccio domiciliare in considerazione del shortage del personale anche fisioterapico che possa fare questa attività. Allora la mia domanda è: chiaramente è fondamentale un training adeguato dei pazienti, è fondamentale l'educazione e tutto quello che lei e gli altri speaker hanno già evidenziato. Pensa che anche sotto il profilo della fisioterapia e della riabilitazione l'approccio di telemedicina potrebbe essere perseguito in maniera efficace? Questa è la domanda. Just to involve our speakers from abroad, I just was asking about the role of telemedicine concerning physiotherapy and rehabilitation.
Sì, allora diciamo che ci sono degli studi già presenti in letteratura, non sul paziente bronchiettasico, ma su altri pazienti con patologia respiratoria cronica, ad esempio soggetto BPCO o anche solo soggetti anziani, che danno delle buone indicazioni sull'approccio teleriabilitazione. È molto vario, nel senso che poi bisogna decidere che cosa vuol dire teleriabilitazione. Può essere una seduta completa fatta virtualmente, può essere soltanto telemonitoraggio, quindi raccogliere dei dati, ma il paziente fa la sua seduta in autonomia, per cui diciamo che in questo momento le indicazioni sono varie, però ci sono dei dati che spingono abbastanza in questa direzione, per cui penso che sia un approccio possibile.
Certamente, grazie. Allora, ancora una domanda per ecco, ancora there is still a question concerning PCD. So this is the question is which is the gold standard today for the diagnosis of PCD? You give a very clear talk on this, but still obviously the question is raising.
Yeah, and you know what, we sit down in PCD meetings and we say, so what is PCD? We have not yet decided because we do not have a single gold standard test. There are two ways in which you can confirm the diagnosis: by electron microscopy and by genetics. Currently, those are the two modalities by which you can confirm a diagnosis, but neither will recognize all patients. At the moment, both recognize about 70% of patients with PCD. So there is no gold standard, unfortunately.
Okay, thank you. So I think the audience can. There is any other question from the audience? So again, I thank you a lot, our speaker from abroad, and I give passo la parola al dottor Aliberti per chiudere la seduta. So I pass the word to Dr. Aliberti to close the session, because I think there is no other question, and I also think we are a bit later on our schedule. So,
okay.
Stefano, se vuoi chiudere.
Okay, so thank you so much. I think that I think that bronchiectasis is a really interesting word, and we all are having a lot of fun working on that. And I'm sure that in Italy too, the awareness of the disease over the past few years increased a lot. So I'm really happy that the Italian Society of Respiratory Medicine decided to have this symposium specifically focused on bronchiectasis. I hope that there will be another one in the next future. There will be the World Bronchiectasis and NTM conference in a few days. A virtual one, 3 days congress. So please feel free to email to me if you want to have any other information about the World Bronchiectasis and NTM conference. And thank you, Martina. Thank you, Peter. Thank you, Amelia. Thank you, Professoressa De Rose. This was a great symposium, and I hope you guys enjoyed a lot as I did. Have a nice evening.
Thank you. Have a nice evening.
Bye. Thank you.
Thank you. Thank you too.